Good afternoon. I am Revathy Sreenath from Philips Healthcare. So today we will be sharing some of our experiences and some of the use cases that we came across working with some of the underserved communities across the world. So the topic that we would be discussing for the next 15 minutes would be on bringing quicker care to these remote communities and how we actually leveraged FHIR to build some of the capabilities. A quick introduction about myself. So I am Revathy Sreenath, been working in the healthcare domain for the past 16 years in different roles as a product manager, software architect, data modeler, and also as subject matter experts for the healthcare interoperability standards like FHIR, HL7, and DICOM, supporting some of the capabilities and assets that we are building in Philips and also outside Philips as part of the certain national healthcare infrastructure backbone as well. All right. So today, in the next 15 minutes, what is that I would be covering with you? So I will touch upon some of the needs that we actually got to understand working with the underserved communities across the world, some of the use cases and some of the problems that we faced. How did we go about solving them, leveraging or taking a standardized approach towards building some of the capabilities and assets? How we actually leveraged an IHE profile called as mACM, which stands for Mobile Alert Communication Management profile, which provides certain guidelines towards what we built, some of the assets. So I will just walk you through that, the approach, what we use, and some of the challenges that we faced during this process. All right, so let's get started. So in Philips, one of our ambitious objectives is to improve lives of 3 billion people a year by 2030, of which 400 plus million people actually are part of underserved communities. What we understood and saw was within these underserved communities, there is actually a tier-based healthcare setup or ecosystems that's created. So typically, we have the community care where the healthcare workers go to the home setting of the patient or the person needing in care to enable or provide timely interventions towards providing certain critical care, especially in case of pregnancy situations. So in India, we actually use the midwifery concept where we have the midwives going to the patient's home to provide timely care and also support for mothers as well as across their postpartum health improvements, etc. That is the first care setting that exists within these communities. And whenever there is a intervention that is required, say by a primary care provider, so that is where the care setting of the patient changes from home to a primary healthcare clinic, where some of the tests or the observations could be captured or tests could be done for the patient to identify some of the problems and how it could be treated in a timely manner. And in scenarios where there is actually a need for an expert intervention, so that's where the secondary care comes in, where again the care setting of the patient changes from this primary care clinic to a larger hospital, which is typically at quite a distance from these tier 1 or tier 2 and tier 3 cities. So what we understood as part of understanding these different tiered ecosystems was the way to improve the lives in underserved markets is primarily to provide access to care at all these levels. And that could happen by providing relevant digital interventions for some of the needs what we have identified. So what did we come across as part of our study and as part of the needs assessment across these different tiers in these communities? So some of the critical needs that we found was there was a need to support a robust alerting framework that could actually span through from a clinical context to a non-clinical context to an administrative or a non-technical context. In fact, it had to cater to a wide spectrum of needs, especially in order to provide timely interventions, be it towards care or be it towards some of the administrative aspects as well. So from the needs perspective, what we could gather is that there was a need to provide alert mechanisms towards crisis response, where timely interventions and accessibility was still a challenge. And that's where these alerts could play in a critical role. In case of emergency situations where there was a need to alert a healthcare worker, a nearby healthcare worker who is residing close to a patient's home. So that's where these alerts could come in handy. In scenarios where there is a need to notify a public health agency in cases of communicable disease. Typically, this was a workflow that actually came in case of some of the use cases that we encountered during the COVID situation, where there was a need to share the patient information with respect to public health agencies in a seamless manner or in a quicker way. Apart from all these things, there was also a need where, supporting alerts was merely not enough. There was a need to provide or track these alerts, some of the actions that were taken in response to these alerts, and how a system could build fault tolerance and provide improved care based on these alerts. The other situations or the use cases or the needs that we came across where these alerts were required was the usual workflows of providing care reminders, education to the patient towards timely medications, their self-care towards taking care of themselves, some of the education part of it, and also any change in the medication, etc. Such reminders had to be sent via these alerts. So this all needs were more from a clinical context. Some of the observations what we had, in fact, was also on the non-clinical or administrative care perspective, right? Where within the primary care clinics, the healthcare infrastructure was also limited. Hence, preventive maintenance, effective utilization of the infrastructure was also critical. So that's where what we understood was provide timely maintenance, with respect to any equipment that is there within the primary care. In fact, actually translated to providing better care or timely interventions in a much more seamless way, because in the primary care setup, all these resources were made available all the time. So some of these needs that we actually found required a robust framework actually to support some of these use cases. So just taking a step back, so how did we actually go about trying to meet all these needs, right? If you see, the usage of mobile phones has actually redefined our lifestyles, right? A quick check on the data shows that in India, there are close to 1,000 million smartphone users in 2022. Similarly, in a country like Uganda, for subscriptions of 100 inhabitants, it was found that close to 17% of people had access to smartphones, and close to 60% of people in 2020 had access to mobile phones themselves. So why not we use this as an effective means to meet some of the needs that I actually walked you through in the earlier slide. So what did we do to solve or meet the needs that were identified across these communities? So in fact, we actually, there was a need to build a robust FHIR-based alerting framework, which could actually cater to a broad spectrum of use cases ranging from clinical to non-clinical context. At the same time, there was also a need that this framework could easily plug into any kind of national healthcare infrastructure or backbone frameworks that we are actually working with. For example, in India, we have the Ayushman Bharat Digital Mission, or the National Health Infrastructure Backbone, which actually provides multiple capabilities and assets towards enabling healthcare connectivity across the country. Similarly, in Netherlands, we have the MedMai, which enables accessibility to timely health information to patients themselves. And also in US, we have the 21st Century Cures Act, which also provides or in fact mandates the use of FHIR towards enabling or making the information accessible. Hence, whatever we built, there was a need actually towards the portability of the framework across all these different markets and the frameworks that existed. At the same time, we also wanted the need also that was that the alerting framework or the capability that was built as part of certain platform assets in Philips could integrate easily within the healthcare system, within a hospital or within a healthcare ecosystem, where it could work with, say, equipments to enabling the maintenance based alerts, usage alerts, etc. At the same time, could also work in a clinical context to deliver or enable clinical alerts to the patients or care providers themselves. The other aspect is when we talk about underserved communities, there is also a need that whatever tech we use with respect to deployment or providing support to the required needs has to be cost friendly, and that's where whatever we had to build should be in fact easily deployable and could be portable across any kind of cloud, public or private cloud infrastructures. So how FHIR actually helped us in creating this capability? So as I mentioned, in fact, we started looking for some of the standard guidelines or approaches towards solving these needs in order to meet the wide spectrum of communities across the countries that we were actually targeting. So that's where we came across this particular IHE profile called as Mobile Alert Communication Management, or the mACM profile. So what does this IHE profile do? Right. So as part of this IHE profile, in fact, to build a robust alert framework, it actually defines certain guidelines where you already have predefined actors. Say, for example, within the this profile, there are two broad categories of actors that actually the profile mentions. One is actually the alert reporter, and the other is actually the alert aggregator. So alert reporter is nothing but a piece of software that would raise timely alerts based on the different context, could be clinical or non-clinical, based on the workflow where it is actually ported. Similarly, an alert aggregator is actually an actor which enables aggregating these alerts from the alert reporter and also disseminating these alerts to an appropriate consumer. Could be to mobile phones used by humans in the form of any kind of push notifications if it's a smartphone, in the form of any SMS kind of a notification if it is the usual basic mobile phones, and it could also move or aggregate and provide information to any underlying platform, which also builds much more robust functionalities leveraging these particular alerts. So that's where these two actors are actually defined as part of this IHE profile. In fact, the IHE mACM profiles provides the infrastructural components that is needed to send all kind of these messaging or alert mechanisms across a wide spectrum of use cases, what I just walked you through. All right, so where exactly FHIR fits in this IHE profile? So as part of the mACM IHE profile, in fact, the profile is actually based on FHIR R4. Primarily, it talks about the two FHIR resources. One is the communication and communication request FHIR resources, which could be leveraged to build this alerting framework. The other aspect is, since it is based on FHIR, the guidelines also mention about how these resources could be integrated with the other resources, like say practitioner, patient, or kind of diagnostic reports, or any kind of clinical information in the clinical context. And similarly, in the device context, how you could leverage on say resources like organization and device and the appropriate device and the location FHIR resources to provide the device-based alert, outside the clinical context. So, in fact, a typical flow is that an alert reporter actually raises the alert, aggregator aggregates them, and then appropriately disseminates to the consumers of these alerts, and at the same time also provides response to the alert reporter. As part of this IHE profile, in fact, two transactions are actually mentioned. One is with respect to ITI 84, which talks about how to create these communication requests and send it to the alert aggregator, and what should be the response. So some basic aspects towards leveraging, the FHIR resources is actually mentioned as part of these profile. One of the key needs what we had was how whatever we built integrates into the national infrastructure, health infrastructure backbones, right? Say for example, like the national registries. In fact, this profile provided also guidelines for that as well, and how we could integrate the alert framework or the alert capabilities, say with national registries like a provider registry or a services registry. So in the Indian context, as part of the national ecosystem, we actually have multiple registries that is defined, like the health provider registry, which is actually a registry of all the doctors or care providers who are existing across the country. And similarly, we also have a national facility registry, and services registry. So these alert framework, what we actually created, could easily hook into these kind of registries based on some of the guidelines that the profile already supported. In fact, the profile also provides some integration key elements towards how I could enable care services discovery also via integrating with these kind of national services or registries. All right. So now, what is the benefits that we were able to get, towards the needs that we mentioned, and also the capability or the framework that we created was, in fact, the basic needs towards providing a robust, fault-tolerant alert framework across the 3 tiers of care was actually taken care, and also. What we additionally was able to do is a few more aspects beyond the alerting mechanisms, where we could leverage these alerts to create something much more towards providing better care. So what were they, right? So as part of the benefits that we were able to get was towards automating some of the initial or manually initiated workflows, across these tiers with much more speed and fault tolerance actually. In fact, we also had a better record keeping mechanism with respect to these alerts and some of the actions that were actually taken in response to the alerts. We were also able to establish an escalation chain for these alerts on who needs to go, or to whom the alert should get passed on to in case there is no response. So that also enabled timely interventions. At the same time, we were also able to create certain task dashboards within the primary clinics, telling, these were the alerts they were raised, this was the task that was done, to provide better tracking, between the primary care providers and the associated healthcare or the midwives, healthcare providers or healthcare workers or the midwives in that particular region. Apart from that, in fact, we also found that we could, using this, we could integrate with certain national deployments, and also in ecosystems where we had the cross enterprise assets where the XDSS were involved, we could also leverage these mechanisms or use the capabilities, fairly well in terms of integration actually. The other aspect, what we also found was we were able to eliminate some of the notification black holes, notification getting lost, and timely intervention, critical messages being missed out. All those aspects, in fact, were addressed in a much more robust manner, based on the framework that was actually created. Yeah, so everything was not rosy. So we had lots of challenges, in fact, identifying some things, and in fact, to move or leverage FHIR, with respect to implementing this framework itself was a challenge, because we had limited information that was available, on how we could use FHIR resources to build the holistic alerting of framework. At the same time, the FHIR resources that were mentioned as part of the IHE profile were fairly of very low level maturity, because it was level 2. We were not sure how it would actually take its course in terms of evolution. So that was one. In fact, there were a lot of problems with respect to standardization of the coding schemes, for especially, say, the alert reasons, status failures. Status in fact was defined, but the alert delivery failure reasons, those mechanisms, in fact, those coding schemes were very well not defined in the profile, and we had to piggyback on certain custom approaches to solve those aspects. So from the maturity point of view of the profile, yes, there are a lot of improvements and standardization that is needed, but nevertheless it helps you build a much more futuristic, well integratable, interoperable capability in terms of the needs that we were able to encounter. So in fact, I've also mentioned some of the references with respect to the profile that actually I touched upon. So in fact, that's all I had for all of you as part of this quick session with respect to some of the challenges, some of the needs, as well as what we did to mitigate those needs, leveraging FHIR. So I'll just take a pause for any questions for the next 5 minutes, in case anybody has anything to discuss. Over to you, Patricia.
Right. And then if, excuse me, if anyone has questions, we have a microphone here that will help Revathy hear any questions that you might have. Or if you want to just contact her using the information that she's provided. You can send her any questions on the Whova app as well as email. So I'm also looking online or on the chat to see if there's any questions being posted. And right now I'm not seeing any. Just give me 1 second. We'll wait just for 1 minute if people don't mind. Oh, okay. We have one question. Let me just hand over the microphone and okay. Yeah. Okay, here you go.
Thank you very much for the presentation and congratulations. My question is really, what next? Is there scope for expanding the system? Is it kind of still in operation? Do you have plans to deploy it in other places?
Yes, in fact, currently we are actually, testing. Sorry, I mean, I just hear myself. Actually.
We can hear you.
Yeah, all right. So the next steps with respect to this particular framework of feasibility is that we would also be testing these assets with respect to different, national frameworks as some of our, beta projects that where we would be deploying it. Across India as well as few other countries. So currently this is the roadmap where we actually test out our solution on the field and see it works. In fact, there were a couple of things which we have already done the test and the primary needs have been addressed. So that was the first finding. Yeah, more towards the secondary needs part of it. So how I could use these alerts towards improving the efficiency of care, right? Towards one dimension, what I just quickly mentioned in my presentation was towards these automated task boards, what we intend to create within the primary healthcare clinics, actually to show, or to immediately, visually show the alerts to the primary care provider. And also see what is the progression of the alerts. That's one aspect, and subsequently the other things would follow in terms of efficiency improvements, where we also may bring in some analytics. In fact, there's a lot many things in pipeline, but yeah, as first step, integration with the national frameworks and see how it scales up. Yeah, that would be the key. Hello.
Okay. Yes. Okay. Thank you. Thank you. That was very helpful. I don't see other questions on the Whova app from our virtual audience, and I don't see any other questions here in the room. So I think we are ready to end the session, and we really appreciate the presentation, Revathy, and thank you for sharing your contact information so we all know how to reach you with more questions during the event. So
Thank
yes,
you.
there it is. So in the app or by email. Okay, thank you.
Thank you, all of you. Thank you for your time. Thank you, Patricia.